We are incredibly excited to continue our discussions about COVID-19 and global health and what we must do now, particularly with this discussion about human rights and abuses in this current era of the pandemic. My name is Rachel Vreeman. I'm a pediatrician, I'm an HIV researcher, and I'm the director of the Arnhold Institute for Global Health in the Department of Global Health at the Mount Sinai School of Medicine. We are really excited to be joined by two panelists today who I'm going to introduce in just a moment. I wanted to let everyone who's joining us know that we'll first have some dialogue back and forth, and then there will be a time for open questions at the end of the hour. If you have questions that you would like to contribute, there's a Q&A box at the bottom of the Zoom screen, and you can put your questions in there. And as I said, we'll move to them at the end of the hour. We are, let's see. So we are excited to be joined today by Dr. Joya Mukherjee and Dr. Greg Gonsalves. Let me tell you a little bit about both of them. So Dr. Mukherjee is an associate professor at the Harvard Medical School, and she's the chief medical officer of Partners in Health, which is an international medical charity dedicated to providing a preferential option for the poor in healthcare. She is both an internist and a pediatrician, as well as an infectious diseases doctor and public health specialist. And she's particularly supported Partners in Health, or PIH's, efforts to provide high quality, comprehensive health care to some of the world's poorest people in partnership with local communities and local health officials. And that work has taken place around the world, ranging from Haiti to Rwanda, Lesotho, Malawi, Sierra Leone, Liberia, Peru, Mexico, Russia, Kazakhstan, and the Navajo Nation. Her clinical work focuses on HIV, multi-drug resistant TB or tuberculosis, mental health, Ebola, the human resources for health, and health system strengthening. She also teaches global health delivery and social medicine to medical students, residents, and fellows, a range of medical trainees, both in the US and internationally. We really welcome you here today, Dr. Mukherjee. We really appreciate having you join us. I am equally delighted to welcome Dr. Greg Gonsalves. He is an assistant professor of epidemiology and microbial diseases, as well as an associate professor of law and a research scholar in law at the Yale Law School. He co-directs a partnership between the Yale Law School and the Yale School of Public Health called the Global Health Justice Partnership, and the Yale Law School, Yale School of Public Health, and Yale Medical School collaboration for research integrity and transparency. His research focuses on using quantitative models to improve the responses to epidemic diseases. And for those of us who do HIV work, he's also a hero because he had more than 30 years of work within the HIV realm, including with the AIDS Coalition to Unleash Power, or ACT UP, as a co-founder for the Treatment Action Group, Gay Men's Health Crisis, and the AIDS and Rights Alliance for Southern Africa. He's been a fellow at the Open Society Foundation and in the Department of Global Health and Social Medicine at Harvard, and he was a 2018 MacArthur Fellow. I'm really excited to open this conversation with both of you and to see where it goes today. What we'll do is I have some questions to start with to prompt our conversation. I would love to hear from both of you with it, and then we'll move from there. So it's first, to start off, what are some of the human rights abuses and concerns that you see arising as a result of the COVID pandemic, both in the US and globally, the things that you are most concerned about right now?
You want to start, Greg? You're on mute.
Hey, so a lot of it is about the sins of omission, which we'll start with. I just got done sending a letter to our medical, nursing, and public health school faculty, actually to repeat what Harvard faculty have done to Governor Baker, is to ask for people to be decarcerated from jails and prisons in the state, because there's no way to do infection control or contain COVID and the novel coronavirus in our state prisons and jails. And so the incarcerated populations all across the country are being basically thrown into the path of this epidemic, and excessive notions of public safety are being used to sacrifice prisoners on the political altar of Governor Lamont here in Connecticut, Governor Baker in Massachusetts, and across the country. Then I do a lot of work with people who use drugs and homeless populations as part of my work. And we asking people to social distance, which we are all doing and working from home. But if you're homeless, it's very difficult to social distance because you don't have a place to go. And even the shelters that you might rely on in normal times are closed because they're congregate settings that are not safe for you. But if you happen to be using drugs at the same time, the hotels at New Haven, for instance, is contracted with to house people who are experiencing homelessness or turning people away. And so there's a whole people who are locked out of our circle of care. People who use drugs, people experiencing homelessness, incarcerated for a start, undocumented, uninsured people, communities of color that basically are going to die in greater numbers because of the way we construct healthcare and the right to health in the United States.
Sure. Thank you.
Agree 100% with what Greg is saying. I would add that it's very important for me always to kind of take us back a little bit as Americans and talk about the fact that we do not have a full set of human rights in this country. We, of course, have massive civil rights violations, particularly among Black and Brown people that have led to mass incarceration and our terrible, terrible immigration policies. But we also, as Americans, we do not have a full set of social and economic rights. And this has never been more apparent than right now. And I think it's a very important thing. And what are social and economic rights? Well, they're right to health care, right to food, right to housing, right to a fair wage when you're employed, a right to a pension. Those are actually have been marginalized from the rights debate because of the Cold War. That is a lot of the rhetoric that's been trying to sort of come back in, brought by people like Bernie Sanders, AOC, and others. But these are legitimate human rights that FDR talked about with the 4 freedoms, that others, and we have basically lock, stock, and barrel dismantled those rights. So I don't see COVID as a specific human rights violation or response to COVID. I see it as cleaving along the lines of just a gross and systemic dismantling of the and ignoring of the social and economic rights that we ought to have. And when you look at like what people are getting as a compensation for this in Italy, in France, it's 10 or 20-fold more social protection. And I think what we will see is that impoverishment, not poverty, but this sort of extraction of wealth from Black and Brown communities and poor communities is going to just show up as COVID. So, I know both Greg and I and you, Rachel, as an HIV person, I mean, this is something that we have to bring to the fore, that it's really time to recognize. And, I don't work in health in the US in general. My work is abroad, and Partners in Health has been pulled into this Massachusetts response. And I've been, quite frankly, horrified at the level of fragmentation, lack of just basic support for people on the health sector side. And, I live in a state that has very good medical coverage. So I can't imagine what's happening in places like Mississippi right now. And so I think we ought to not use, people are saying a silver lining. To me, it's not. It's a reckoning. It's a reckoning with the political choices we've made to dismantle and never adequately support basic social and economic rights.
Yeah, certainly. I completely agree. I mean, I think it so exposes here what, as you said, what has been dismantled, what has not been valued, how public health has been cut, the issues you were talking about with prisons and jails, certainly the many weaknesses of the fragmented for-profit health system and where that leaves people at this moment. I think it's both this revealing as well as the ways, and then it perpetuates those things that have been in place already along those lines. Completely agree. Do you, Dr. Mukherjee, I think, and Dr. Gonzalez as well, we both have experience working in global health settings as well. And it's an interesting time to be focused, at least for me, in terms of the needs of the United States with that. How do we kind of think about the discrepancies between the public health systems and how they protect or support the human rights of people in a global setting versus here in the US? What are things that are, I guess, digging in a little bit more to this question of what's revealed about our public health system and how it does not support human rights in the United States?
I mean, so, I remember when Joya's colleague, Paul Farmer, was at Yale for a lecture, and we were on a panel together. And I remember saying at that point that infectious diseases are always going to be with us, but pandemics are human creations. Mm-hmm. What happened in 2014, 2015 in West Africa with Ebola, what's happening in the DRC over the past few years with Ebola, all these infectious disease outbreaks are preventable and addressable, but it means sort of securing social, economic, and civil rights, not just for the US and Europe, Australia, New Zealand, Japan, it's for the globe. And I think Joya's comment how we've sort of, over decades, we've sort of denigrated the need to build this up internally in the US, but we really have exported this ideology all around the world.
Amen. Amen. Yes.
Yes, and the chickens are coming home to roost, right? Yeah. So like we keep wondering about the conservative governors in the United States who won't do stay-at-home orders and whether we'll be able to sort of deal with the virus in a patchwork in the United States, but then start thinking about the rest of the world. The United States, first of all, is sucking up all the sort of commodities for testing and personal protective equipment around the world, leaving many countries in which Joya and I have historically worked, or Joya continues to work in, without the things they need, because the US is sort of cornering the market on lots of the goods that we need right now. My big worry at the moment is that because we are so focused on the domestic epidemic, that countries in the global South are going to be left without any sort of solidarity from their northern neighbors over the next few months and years, and are much less equipped to deal with this on their own. And again, if we can't address the COVID epidemic globally, we're just sort of setting us up for seasonal return of the virus, and sort of a flu and coronavirus season every year that the world is going to have to sort of have to live with.
Yeah, I agree. Joya, Dr. Mukherjee?
You can call me Joya, that's fine. Okay. I prefer it. Yeah, first of all, Greg and I have worked together for over 20 years on this, and I just want to thank him and leaders of the movement for HIV treatment access for really changing the narrative. And he knows this. I've dedicated a lot of space teaching with him and about that movement. And why was it so important? Because people like Greg fought for HIV treatment, but they didn't say, okay, now I'm good. They said, no, this is basic and fundamental injustice. And I remember the first time we met, Greg, I've always been trying to think, is this when we first met? But I think it was in Kampala, Uganda. And I thought, what is this guy? What does he know about Africa? I had already worked in Africa. I was like all hoity-toity. I was like 20 whatever years old. And then I realized it's really about global solidarity. So we will make a mistake, and I think we will continue to make this mistake if we think global health is really about somewhere else. Global health really has to be about solidarity, human rights, addressing the general burden of disease, and really wanting the same standards for our brothers and sisters anywhere as we want for ourselves. And the only light in the darkness in the 90s and the early 2000s was the treatment action solidarity from people from the global north standing together with the global south. And it is just critical that we do that. And I would add to that because of the values, the neoliberal values that the market will fix everything, there's no point in investing in the public sector, it's going to cut into profits, Milton Friedman's dreams, because we exported that for 40 years with the neoliberal project and basically undermined African governments' abilities to govern, because you need to have a public contract to govern, right? You need to have public schools and public universities and, to govern. And so because we've done that, these countries have been just absolutely hamstrung at every turn, basically until the international. So, I started working in Africa in the early 90s, where there's nothing except a couple of charity hospitals, right? Because there's no money. So, but one thing I could say is that once people had the resources, many countries absolutely nailed it, right? Absolutely nailed it. They have better HIV outcomes than we do in the United States. They are much better at prevention. They're much better at what we call task shifting. And so I was in Liberia and Sierra Leone in February 15th. I landed in the Lungi airport, which is a tiny little nothing of an airport. I was temperature screened in people with full PPE. I washed my hands with a bucket, chlorine. They wrote down my phone number, what hotel I was staying in, where I was going to go, and told me, if you are sick, blah, blah, blah. They took down my travel history in February. I returned to JFK, nothing. Yeah. Nothing. And this is the problem, is so we've got brilliant colleagues around the world who are just implementing stuff based on what they've learned. They don't have the resources that we do, but there's a lot more work. I can't believe what's happening in Rwanda, and I'm going to do the math, but their first case, I believe, was somewhere around March 15th. And so far, about the time the Seattle stuff started, and so far they've had 80 cases. That's it. Because they've chased down every contact. They put people in isolation. The government gave them food and health care, and even people who are refugees have health insurance. So, there's lots of imperfections in any country, but my God, the response on this limited thing. So there's a lot we can learn in our broken system from places that are really being incredibly proactive and trying to protect their citizens and non-citizens, their people.
Yeah, the people that are there and impacted. Greg, do you want to add to those thoughts or follow any?
I can't remember what the original question was, so let's move on for a second.
Global. How does the U.S. thing make us think about global work?
No, I look at it. It's very funny. I was on a call last week with colleagues from Nepal, from South Africa, from Uganda, from several other countries, from Kenya, and I don't think it's an accident that HIV people are in the lead in some of these national responses, because they've shown that they know how to do it. As Joya says, they can do it better than we can. Right. The South African infectious disease doctors like Francois Venter and Linda Gale Becker and others, are all over COVID-19, yes, as infectious disease doctors, but also because they know how to mobilize, they know how to mobilize civil society, they know how to sort of pull on resources to get things done, and they know better than to take no for an answer. And so I'm seeing a lot of people who are part of our HIV/HIV-TB movement, sort of filling in the gaps. Even the people who are working for community-based organizations that are not, quote unquote, medical NGOs. So it's fascinating to watch, and it gives me hope that something we built around HIV 25 years ago has stepped into the crisis to help and in a constructive way.
Yeah, my own story actually reflects much of what Joy was saying as well, but echoes that. I started working in Kenya in the early 2000s when there wasn't yet antiretroviral therapy available for HIV, and was just coming in at the process of when we were able to start moving that forward and build that. Have always felt this enormous debt as well to the work of the Treatment Action Group and others, and really moving that forward and not allowing it just to be a resource that was only available in the US. And, you know, so seeing what it's taken to move from a point where even still we've had many more thousands dying than we should from HIV continuing, but still being able to roll out treatment, access to prevention, and move these things forward. And then just as you're saying, to see now how not only have we been able, you know, over the last few years, especially to pivot some of that infrastructure to provide better systems to manage chronic diseases and other health challenges in settings globally, but then to see how that does offer a framework for containing a pandemic like this. And, you know, really just hoping that we can be, you know, I guess humble enough is what strikes me here in the US, to look at those lessons learned and let some of it come back to inform how we're responding as well. It's like, you know, I agree with you. I was in Kenya in January and February, and again, like seeing a much more you know, nationwide response that was taking it seriously and focusing on containment. Of course, I'm still incredibly worried about what it might.
Of course, yes, of course.
Knowing the extreme limitations of especially critical care options and so on in a number of settings, but grateful for the ways in which that public health infrastructure, and just as you were saying, Greg, the expertise of the people who've worked in HIV, and including the community health workers, including, you know, people who are used to trying to move care between even rural and remote communities and health centers and make those connections and so on, are pivoting to figure out, even if they can't do things face to face, how they can be involved in education, in making sure people are receiving essential medicines and promoting the care systems in that way. So I guess let's turn a little bit. I would love to hear your priorities for what policies you think most urgently need to change as we consider this pandemic. And, you know, we can think on a number of levels, because I'm sure I wish I could give you magic wands that would change these things. Yeah, exactly. It would be perfect. You know, I think, you know, you're thinking about the federal response, congressional responses, what states are doing, et cetera, but also, you know, at local levels as well. I'd love to hear about where you would like to see changes be made.
So, you know, the president got up at the podium yesterday at his daily, I don't know what it is anymore. It's not a daily briefing on coronavirus, his campaign rally, and basically told the governors they were on their own, right? And you're seeing a strange thing happen now. You're seeing the governors in the Northeast, in the Midwest, and on the West Coast banding together to sort of form a more perfect union of capabilities and initiative than the federal government can, right? They realize the task that's ahead of us is an enormous task, right? One is the scale up of testing, contact tracing, and isolation. And, you know, Joya's Partners in Health is part of that effort in Massachusetts right now, but all across the country, we're going to need to scale up the commodities and the people to do the job. You know, that being said, you know, that's not the only thing, right? If I'm isolated, if I'm taken out of my home because I am COVID positive and I'm a single dad with 2 kids, who's going to take care of my kids? You know, I live at home with my partner and my dog. If we both get sick, who's going to walk my dog? I mean, there's a sort of social support network which needs to sort of rise up as well. That's sort of not just community health work, but community social work that's going to happen all over the country. That's going to take an enormous amount of federal resources. The state and local governments can't afford to do this. You can see that the governors are starting to band together because they don't see hope coming from Washington, D.C. What I'm terribly worried about is Mississippi and Alabama and Oklahoma and Nebraska, governors who basically are in lockstep with the president, who really don't see this as a problem, and didn't see public health or healthcare or social and economic rights as a problem. Or science. And so we're going to see a medical apartheid happening in the U.S. in which, you know, these governors who've banded together. Look, there's some Republicans in the mix too. It's not a sort of partisan affair, but we're going to see recovery happen here, where, frankly, the states of the former Confederacy are going to are going to lag behind in their ability to control this epidemic, and it's going to be poor brown and black people who are going to suffer in these former slave states who are basically, we talked about the roots of this epidemic in sort of a 50-year history, a 60-year history. But remember, the reason we don't have national health care in the United States is a legacy of slavery and white supremacy, and basically keeping services out of former slaves in the American South. And so this is going to be a weird period in which what needs to be done is going to be handled by the states and localities with very little federal support. And then there's going to be a whole set of states who just basically reopen in a careless way, making things worse. And so we already see governors mobilizing, we see mayors mobilizing, but there's really no plan at the federal level. The president has no interest. He just keeps going, when are we going to open? When are we going to open? When are we going to open? It's like, it's I don't know, I can't even fathom what's going on at the federal level right now. It's an absolute abdication of responsibility.
I completely agree.
So, to me, it's such a great question. And I think, again, I don't see a silver lining. There's no silver lining. You can't talk about a silver lining when the pain and suffering is so enormous. But I think there should be a reckoning. And the reckoning needs to be a political one.
Yeah.
Because all health is political. All health is about political choices. And so I think there are several things that we need to pressure for on the federal level. One is Medicare for all. I mean, you cannot have health insurance tied to employment. And this is not going to be over when the economy opens. This is going to last. And so we need to look at the rebuilding of an American social contract in the same way FDR looked at the New Deal. And that crisis was largely a financial set of crises. This is really a health crisis that has tanked the economy. So the solution should be a large set of health things. Medicare for all is one. Another thing is a universal basic income. The fact that we dither about whether or not people can get $1,200 as a one-shot thing, and then Steve Mnuchin calls it bridge liquidity, is just the most absurd and depressing thing I have ever heard. The second is, I think that we should think about what are the basic issues we need to rebuild in this country. We've got to end mass incarceration and have broad amnesty. We have to, and I've worked in the prisons in Russia and Kazakhstan and elsewhere, and there are many problems there. But when the epidemic of MDR-TB was recognized, there were some really good prison reformers in Russia. They didn't necessarily reflect the administration, but within the Ministry of Justice, and they saw MDR as a real indictment of their human rights in prisons. And they had several mass amnesty bills at the federal level and let people out of jail. And they were putting people in jail for petty property crimes at the fall of the Soviet Union. So that's what we've done. And so we need some really bills to de-incarcerate people, and also with a reckoning that we made a mistake, that putting people, 3 strikes and you're out is a mistake. So I think we need to have a series of legislation, and God help us if we have Trump again. I mean, we have to all get out and do whatever we can to make sure Joe Biden is elected. I mean, I'm a Bernie Sanders supporter, but if we don't change this, and I don't think Biden is perfect, but we can at least pressure him. Mm-hmm. And I think, so Medicare for all is one, really passing bills that have to do with mass amnesty. And then I really think funding of community health. So it's not only Medicare for all, because that covers the system we have, but the system we have is broken. It's a broken system. And so I don't only want Medicare for all. I want rebuilding of community health centers, refunding of keeping people well. Community health centers are a legacy of the civil rights movement, right? And they've been defunded over 40 years. And that is where poor people access healthcare. And yet, because of our stupid reimbursement structure, they were furloughing workers in the middle of an epidemic. What kind of crazy structure do we have in the country that we can't put people to work? So Medicare for All, rebuilding the public and primary healthcare infrastructure, mass amnesty bills, federally legislated, state legislated, not just, oh, I'm going to be nice and let 1,000 people out of prison. No, we made a mistake. This is a reckoning, right? And then I think the other thing, I think that we should create now, and maybe Trump could be talked into doing it because he's so egotistical, slap his name on it. I actually don't care. We need a massive jobs program in this country that is related to ending the epidemic, right? And that should be community workers, and as Greg says, social workers. We need to make sure people have their groceries delivered, that they, you know, whatever it is, you know, we need to turn all our hotels into housing for homeless people, unhoused people, and you know, and put hotel workers back to work, restaurant, you know, we could have, instead of putting $1 trillion into propping up the stock market, instead of putting $1 trillion into small business loans, which will never be able to be paid back, instead of doing that, let's create 6 million jobs, 10 million jobs, right? In line with ending the epidemic, right? Yeah. And have some of them be permanent.
Yeah. Yeah, you know, I was thinking as you're talking, I would add, and I think this ties into what you're saying at the end too, I think housing as a critical issue with this. I mean, certainly the systemic inequalities and health and economic problems that are in this mix, you know, as you were saying, Greg, too, especially compounded by the issues for those who are using drugs, compounded by the issues for a lack of care and support for those with mental health challenges, compounded with the issues of imprisonment. But, you know, we have a close partnership with Elmhurst Hospital, which is one of the larger hospitals in the New York Health and Hospital system in Queens, in an incredibly diverse local area, and they have just been it has just been an overwhelming tragedy, the pandemic impact there. I think that the heroes of this pandemic are certainly in this. I mean, the Elmhurst staff and healthcare workers and teams are they're doing an incredible job to try to provide care for the numbers of people that they're seeing, and yet the you know, the population that's being impacted there is very disproportionately brown and Black, and with that, the transmission that happens when you have if you're not keeping someone in your incredibly overcrowded ER or ICU, and your only option is to send them back to an apartment where their entire family and perhaps extended family or multiple, you know, workers and people are residing, is only, you know, obviously, as you know well, in epidemics, by like making things worse and worse. So that, you know, the transmission rates are just so terrible in these settings, and yet there are not other clear options.
Well, but think about how many hotel rooms are vacant in New York City at the current moment.
Completely agree. And I think, you know, I think how those could be mobilized for the homeless, for relieving congestion in high transmission areas, for so many of these things. Completely agree. And if you can convert the Javits Center into a hospital in a week, I think there must be, you know, ways with the right political will that you could address this housing issue.
Yes, and that's why I think it needs to be kind of a series of a package of things, from housing and really recognizing the reckoning about social and economic rights, and about the disparities in race and class. And, you know, yeah,
I mean, the other thing, you know, I went to the grocery store yesterday, and people were not wearing masks or gloves behind the counters. And then I got a phone call from a reporter in DC that said the US Chamber of Commerce wants to indemnify companies for infections that happen in their workplaces. Meanwhile, they're also pushing for essential services, not just healthcare settings, but grocery stores, pharmacies, to go back to work.
WWF in Florida.
Yeah, and so never let a crisis go to waste. People who want to roll back workers' rights, abortion rights, Texas is trying to ban abortions right now. So all, you know, as we have to build towards a more just future, the right wing is out there sort of, and the corporate class out there trying to erode workers' rights, erode reproductive and women's rights. And I think we need, and it's all happening under the cover of this chaos and fog of the epidemic. And we need to be pretty clear that, you know, when we talk about frontline workers, we're talking about people who are still in grocery stores, making our lives possible. And I was just astounded as I was walking through that store going, these people are going to be, you know, are going to get infected. This is it's not just the hospitals or hotbeds. I bet when we start testing people more widely, we're going to find grocery stores, pharmacies, gas stations, other places that people go all the time are going to be full of the novel coronavirus.
Yeah.
So,
you know, Joya, could I ask you, as we, especially, you know, thinking about that issue of testing more widely, and of course that we need to do that. But I was thinking about the response in Massachusetts and the Partners in Health model and so on. Could you tell us a little bit more about that, kind of walking through what that looks like and where there may be ways to, I don't know if it's compensate for some, or at least ideally be a model for how we might move forward some of the what's going to be needed to address the next steps in this pandemic?
Yeah, so, you know, look, contact tracing is nothing new. It goes back to John Snow in the 1850s. So it's not new, and we've got great colleagues in the United States across the country that are good, decent humans and civil servants who are doing contact tracing every day. But, you know, in this pandemic, they are so outmatched by the incompetence of the American government as well as the crisis of the virus. And so we're trying to scale that up rapidly using some technology, but also to hire, you know, 1,000 people. Now, if we at PIH can figure out how to hire 1,000 people, you'd think the federal government could figure out how to hire 10 million. Honestly, like, it's not that hard to put people to work doing this. So we have 3 cadres of workers. One is one of the kind of little public health nerdy things that we did to try to scale is decouple case investigation and contact tracing. Normally they're done by the same person, but to get to a geometric scale, you need many, many more contact tracers than case investigators. And so we have a cadre that's the case investigators, and they're the ones who really interface with the Department of Public Health and try to be force multipliers for that system and enter things into the record of the state. Because that's the other thing. There are a lot of private companies now also circling that want to do this and do that, and Apple and Google and everything. But, you know, at the end of the day, the record, the epidemiologic record, is the state's record. And that's how it should be, so we can track the epidemic and invest in our public health infrastructures and get the data we need about vulnerable communities so that we can heavily resource those communities. So that case investigator thing, we've hired, you know, some, but that's, you know, also really the front facing with the Department of Public Health. Then they do the enumeration of the cases, they put it into a call center kind of software, and it gets spits out to a contact tracer. And those are 10 to 1 from the case investigator, so that there can be more calls going out to say, you might be a contact, you are a contact, you are a contact. Okay, so that would be the standard approach. But then we also, because our organization is very focused on vulnerabilities and impoverished people, we said this isn't going to work unless we have a cadre that we're calling the COVID resource manager, or something like that, that really, so as the contact tracer is saying, okay, you've been a contact, how are you? Are you okay? Do you need to be referred to clinical care? Then 2, this is what quarantine means apart from social distancing. This is different. And then 3, can you do that? Right? Are you in a position to do that? And if you're not, then you get referred to the next cadre, which is this resource manager person, who is a social worker or a social worker-like person trained in those kind of things, and knows the landscape. And we're trying to work more and more with grassroots communities across the state to say, what are the resources in this particular community, right? And how do we then connect people? And our feeling is, and you know, the governor, who is a Republican, he's showed tremendous leadership here and has said, this is only a good plan if it works. So, like, tell us what you need, right? So then connecting with these grassroots organizations will say, okay, this community has this food pantry, this, you know, and that's their job, to connect that person so that they can quarantine. And then if they can't, you know, that would be another level, maybe a hotel, whatever. That hasn't been totally built. I mean, it's all building by doing, but recognizing right up front that the ability to do social distancing, quarantine, isolation is highly dependent on your economic situation. And so that's what we're scaling. You know, we started on, the governor announced this on April 3rd, and we started our first calls on Sunday. So just about 2 weeks later, and I've called already about 3,000 contacts, which is pretty great. And hope to be able to scale to, you know, do 30,000 a day if needed. But I think, again, we're going to have to really invest as a nation the resources to do this. You know, it's not going to work. And this is the criminal thing about the United States. The level of inequality is so profound. I mean, I was on the phone talking to colleagues from a city that I'm not going to mention, but it's a poor city in the north, mostly Black and brown people. And these public health people are so good. They so understand what they need. They're begging for help, and they've been basically sort of a secondary part of the response as we all focus on hospitals and ventilators and PPE, and that's fine. Like, I get that, but that's, you know, that's just the symptom of the crisis. It's a symptom. You know, it's like if somebody had malaria and you're just treating their fever, right? The fever is hospitalization, but the sickness is our racism and massive inequality and lack of structures at the community level.
Completely agree. Very powerfully.
That was the first time I cried in the epidemic talking to those people, because I'm like, they know what they're doing. They just need to be resourced to do it.
Wow. Before we turn to the questions coming in, I wanted to ask a question that I was thinking of as we were talking here, in addition, about stigma, and sort of thinking about, and I mean, I think what you were just pointing out, Joya, about the deep roots of these problems, I think is incredibly powerful in this. And in stigma is sort of that bubbling up in that fashion, I feel like. But, you know, after from my HIV work, we work a lot related to how the impact of HIV related stigma impacts every aspect of a family's life, even if they're not overtly experiencing discrimination that they can point to in a physical way, how their fears about that and perceptions of it, the very real risks that they take related to disclosing their HIV status, and the ways in which it gets internalized impact their ability, and, you know, impact one's ability to take medicines every day, to, you know, to engage care for your child, and how you might or may not be supported in that. You know, and of course, because I'm a pediatrician, a lot of it is trying to support adolescents in their journey towards adulthood and what it looks like to have HIV as part of your story. And I've been really struck by the ways in which, and I think much of this stems from characterizing initially the pandemic as something being brought by outsiders or tied to immigration, or being characterized as somehow limited to a certain group of people who are not us, in contrast to what to me is incredibly clear, that this is a global problem that has no borders, and that despite there being, of course, very real disparities and the impact that it has on people. So I guess I would love to hear commentary or thoughts about both how you see stigma evolving as we respond to this pandemic, and also what we can do to actively combat that stigma, in addition to, you know, the fights against these structural issues and trying to roll out positive changes as well.
I mean, so look, we know the president is whipping up xenophobia and xenophobia against Asian Americans, and we know violence and harassment started months ago, in February now, and we need to answer it in our own communities by being good neighbors, but also sort of take legal action and report these things when we see them. The two other things is that I remember when the Ebola epidemic happened in West Africa, 2 people came back from Liberia to New Haven where they were quarantined, and people were bringing them groceries to their house. And their neighbors were flipping out and calling the police and harassing them in other ways. And the idea is that as we start to scale up contact tracing and isolation, we're going to have to figure out how to sort of manage people's fears around the virus. The thing that's worrying me lately is about antibody tests. Are we going to have passes that say, quote unquote, I'm clean? You know, we know the sort of pejorative use of the word clean in the context of HIV prevention, in terms of having sex with, you know, gay men having sex with each other. We're going to say, oh, Greg and Joy are clean, they can go back to work. Rachel and Amanda, you know, sorry, you know, you had a negative antibody test. You're not going to be able to go back to work for a few weeks until, I mean, there's going to be a zero stigma around whether you are recovered, and it could be used in pernicious ways around child custody, around who gets to go back to work, about student visas or other kinds of visas. So I'm very worried about antibody testing and how it could be used in a sort of nefarious way.
Agreed. Especially when we think about vulnerabilities of why people get sick. So it will be another kind of apartheid, as Greg said earlier. So I think that's very concerning. The other thing I'm very concerned about is the ethics that's being rolled out about how ventilators will be rationed. And everyone said, well, we're just making these plans now just in case. And, you know, my state, the ethics are pre-existing condition. And pre-existing condition basically in the US is just zip code, right? I mean, death rates, diabetes rates, COPD rates, any of those pre-existing conditions that would keep you off a ventilator, you can guess the prevalence by zip code. So I just feel like, and you know, that's been brought up to people, well, you know, but there's no other rational way to do it. Well, there are. And in fact, I would say we have to reinvest in the sickest people, right? Because those are the people whose lives are most at stake, in fact. So, I worry about this kind of false rationality, which we saw a lot in HIV. Well, prevention is 28 times more effective than treatment. Like, based on what? Based on what data? And the same thing with this sort of rationing. If we start to say we're going to use pre-existing conditions as if that's neutral, it is not neutral. And there's a lot of discussion about that. And I wrote a scathing op-ed that I could not get in anywhere. Washington Post, New York Times, whatever. You know, this is not ethics. This is eugenics. You know, this is a kind of like deciding on people's fate based on, it's worse than, I mean, there's nothing worse than, but I mean, it's basically, you know, based on the color of your skin, essentially.
Yeah.
It's so dangerous, and it poses as rationality.
Sure. we're getting some questions, and I'd like to turn to those for a little bit, because they're really interesting. We start with one. It, of course, thanks you, as I do too, for the thoughtful, invigorating discussion. It says, for healthcare professionals, and especially trainees, how can we publicly advocate for the kind of reckoning that we need? What are the most effective ways for us to enact change while balancing our professional obligations and our civil responsibilities? Either one of you want to take that one?
So okay, I think it's part of your professional obligation to speak up. You know, Joy works in a medical school, I work at a public health school. There are people there who think of themselves as technical people. We do medicine, we do public health. Medicine and public health are political, right? And, you know, if this didn't show it to you, it showed it to you. You know, the point is that trainees, you know, physicians and people with advanced degrees, particularly physicians, have a lot of political clout in the United States. They're a very well-trusted profession. And I think at this point, they should be on the phones, they should be doing emails, they should be doing texts. You know, there are people who need your solidarity right now.
Yes.
Prisoners in the state of Massachusetts and Connecticut and all around the country need your solidarity right now. You know, Governor Lamont, you know, we were supposed to have a call with him with prison advocates on Monday, and he canceled it. You know, the point is that people people in power can turn a blind eye to people who are advocating on behalf of the poor and the marginalized. So people who have political power by virtue of their employment or profession need to speak up. There is no excuse. It's just as important as washing your hands and donning your PPE, that once a week, figure out who needs your voice, right? Once a day, maybe I'm pushing my luck, but once a week, you should do something that is about amplifying somebody else's voice who's dying to be heard, literally dying to be heard.
Thank you. Yeah. Joya, do you want to add anything to that?
No, that's terrific.
Great. A question, where do you see healthcare disparities a year from now? Joya, do you want to start with that one? Maybe there are two alternate paths, but.
I mean, they're already much worse. Any epidemic makes health disparities worse, right? Mm-hmm. There's no epidemic that preferentially chooses rich people. Mm-hmm. And so I think they'll be worse. I think the question is how loud we can be in demanding change and demanding the reckoning. So it's going to be as bad as it'll only be less if our advocacy is successful and strong and organized, right? That's the only path to it being less. Mm-hmm. There's no question that it will be worse, but how can we organize? Sure.
Another question for you, or are you okay if I ask you one more there and we can circle back to Greg? So thinking about our ideas about hotels and how we might
I saw that one.
Yeah, how could hotel workers, we were talking about the concerns for grocery store employees and pharmacy employees, etc. What about hotel workers?
Same thing. I mean, if we're going to put people on the front lines, again, like one point I wanted to make earlier, which I can make with this question, is if we're going to make a massive system in a state or federally, and this is another lesson. It's a kind of nerdy lesson that we've learned from HIV, which is, to sum it up, you could say if you build it, they will come, but it's not quite that simple, because part of having enough PPE, part of having enough tests, part of having enough hotel rooms is planning in advance, like saying, okay, we know it's this spread, that we're going to prepare for what it's going to look like on week 4, and this is the many hotel rooms we need, this is how many PPE, and giving yourself the time to get that stuff together. Part of this test thing is there's no planning, right? So is it, and that's where I think we should not put anyone in harm's way without PPE. So if people are cleaners, they should have PPE. But then we have to plan, like, how many hotels, where will they be, how many rooms? I mean, this is, and the reason I say HIV is so important is the only disease, and again, I'm an infectious disease doctor and run a large organization. It's the only disease where we did what we called morbidity mapping, where we said, okay, this is what we think is the level of HIV. And then to get to universal coverage, how many tests do we need? How many drugs do we need? How many people need to be trained? Where are they going to go, right? The planning was based on the goal of getting to 100%. Nothing else does that. That's why we're behind in TB and malaria and everything else. So if we said, okay, we know, like, use some swag, and we do lots of math at PIH, right? We believe in that. Use some swag. Say, okay, for Korea to successfully control, they had to test 2 positives for every 98 negatives, right? So that's actually how many tests we need in this country. And then you can localize where the epidemic is. We know what counties they're on. So this county needs this many tests, and this county needs this many tests. And then we can say, okay, this is how many people are sick. We estimate, based on something like free and reduced school lunch, that this percentage will need additional social support. Then we plan that. But there's no centralized planning. It's so fragmented. And so I think, yes, grocery store workers and hotel workers should be protected, but they should be protected with an ongoing plan, not just sporadic kind of charity and, doing whatever we think and being overwhelmed. And there are ways you can map out the numbers. It won't be perfect, but it will be good enough to get you started, and then you can iterate. And that's what I don't see anyone doing. And it's terrifying to me.
Yeah. Planning and math are obviously
Yeah, math is good.
parts of yeah, it's like our math.
I mean, imagine if we had started,
No,
you know,
it's
the
true.
global fund
Yeah.
and said, we're just gonna, you know, whoever shows up, we'll just test them and we'll see how it goes. Like that would never have worked. It would never have worked. We said, how many people are there? How many people do we reasonably think we should get to this year? This is how many drugs we're procuring. If we think that about, you know, 5% of tests will be positive, this how many test kits. And then we were learning as we were going, but we never had the goal to just kind of, let's just see what shows up. And that's what we're doing with coronavirus. So let's just see what shows up and then we'll just like go and get some ventilators. Ridiculous.
Completely agree. I'm kind of skipping through the questions, but I want to take a moment because I see two that apply to groups we haven't really touched on much, and just to see if we could raise them. One is and I think this goes a little bit with some of the ethics questions, but there's a question about, I think, a population that need further attention is the disabled. So thinking about disabled populations within this. And then another question about the relevance of undocumented individuals, how they're being affected, and kind of where they fall in this discussion as well. So kind of pulling those out to spend a few moments, I think, in a deserved way, talking there.
So this is maybe not a specific question to sort of the larger group, larger world of people living with disabilities, but I've been talking with a lot of people who have ALS, right? And I've been talking with them for several months now about drug development pre-COVID, right? So we were on a call last Saturday, and people were saying they can't get parts to their ventilators, right? People who need respiratory support because they have some sort of degenerative disease which is compromising their respiratory function are not being able to get access to these parts. They're also saying, I can't go to an ER. Right. There's lots of things about my life that are not going to be dealt with if you know, I'll die in an ER, I'll die if I go to an ICU, you know, and so we're not thinking about the sort of complexities of people's lives when we have these sort of broader conversations about the response to COVID. I mean, pre-existing conditions, yes, but people who are living with disabilities, you know, had to struggle to get access to healthcare all their life, and I think like where are disparities going to be a year from now? I don't have a lot of hope. I think we're going to see a lot of excess deaths, particularly among people who are living with disabilities or other conditions that are, you know, distantly related to anything we're talking about, because we've diverted a lot of attention, resources, money to thinking about COVID, because we have such a fractured healthcare system. We can't do more. We don't do the planning that Joy is talking about that have let us sort of deal with this in a comprehensive, targeted, rational way.
Yeah. Joya, any last words you'd like to add? I know we're approaching the end of our hour, and I really appreciate everyone's time here.
Oh, there we go. No, you know, thanks. It's fun to be with you guys. It's a bit of venting.
Venting is good.
Venting is good. I mean, it's just
action is better.
Yeah, venting and action. But you know, so I feel like I spend every day doing action, and I get to blow off a little steam.
Yeah, no.
So I think that's probably a good motto for us to leave with for this particular discussion, though, in terms of venting being good and having an important place, but also that action is even better. Yeah. And I think really taking what you said, Greg, to heart about at least once a week, if not, you know, multiple times a day, trying to use your voice and trying to do something specifically as well. So thank you so much. To mention to everyone, we did record this session and it will be posted. Next week, our webinar event is going to be focused on community health workers. Actually, the title for next week is "It's Not Over Until It's Over for Everyone," and talking with community health workers, solidarity, and what it will take to beat COVID worldwide. So if you can join us on the 24th for that as well, we'd love to have you. And again, thank you so much, Greg. Thank you so much, Joya, for spending this time with us today. I really, really appreciate it.
Thanks, Rachel and Amanda.
Bye.
Thank you very much.
Rachel.
Yes, Amanda, for organizing. Bye.
Thanks, Amanda.